Good afternoon. It's the 5th of September 2020. This virus surely keeps you on your toes. Every day there is new information, and fortunately for all of us, a lot of it is of very reassuring nature. Now, the mortality in India is 50 per million, which again is much less than the Western countries, which go up to 700 per million, 600 per million, and in fact less than most countries on the planet. The other important thing is that in India, so far, almost officially, 4 million people have been infected, and I personally believe that 40 million people have been infected, but the mortality is only 70,000 or less than that. Even if someone suggests that these numbers have been manipulated, let us presume that 100,000 people have died because of COVID-19, which again is very, very, very less. The reason is very simple. One is that our population is of the younger age group. Young people, even if they do get infected, do not become victims of this virus. The other reason is probably we are now more aware of how to treat the virus, and we have certain modalities which are effective in treating this virus. Now, the doomsayers, the chaps who were predicting that millions would die in this country, that we don't have the medical mindset or we don't have the medical infrastructure to handle COVID-19, have definitely been proven wrong, but they still persist in their obnoxious predictions that millions will die and that possibly we are fudging the mortality figures. The sad thing is that the leading media houses, including leading journalists, have been giving these doomsayers platform day after day, regularly, so that they could espouse their strange predictions. The fact is that mortality is much, much less in India as compared to the other countries, and this may not be because of the offensive or the effectiveness of the government. It is because of the nature of the virus and because of the nature of the South Asian living in India and in the subcontinent. Now, let me elaborate that young people firstly do not get infected, and if they do get infected, the virus does not unleash very, very serious problems in the young people, and very, very few young people die. And to buttress my statement, I will quote a recent paper, which is an excellent paper published in one of my favorite medical journals, which is the British Medical Journal. This has data on 651 children admitted. These children were from almost 1 or 2 weeks to 19 years of age. 50% or a little more were white children, 12% were South Asians, and 10% of these children were blacks. The most important fact is that out of these 651 children admitted in British hospitals, only 6 died. Let me repeat, only 6 children died, and all 6 children had serious diseases along with COVID-19. Of these 6, 3 were infants. That means they were under the age of 4 weeks. All 3 were either were premature or had serious complex congenital heart disease or had bacterial sepsis. The other 3, between the ages of 15 and 18 years, one of them had cancer and was on chemotherapy. The other 2 had serious neurological diseases accompanied by respiratory problems. So now we find that out of 651 children, not a single healthy child died because of COVID-19 in Great Britain. 6 children did die, that is just 1% mortality, but all 6 children had serious diseases. So this is very good information. This is scientific information which emphasizes and makes me personally upbeat that this disease does not kill young people. And it makes me upbeat because I am and you are also aware that in India, the majority of people are below the age of 30 years. Now, we come to the treatment part. Before I come to the treatment part, let me elaborate that one has to be very careful of the news which is transmitted, whether by television or by newspapers or by the radio, regardless of what is the source of that information, particularly regarding COVID-19. Now, you may not know this. This may surprise you that there is enough evidence, there is enough data that this big philanthropist has been donating extensively to news channels and news barons. Now, the donations almost exceed $250 million. That is 25 crore dollars, which is actually more than 1,800 crore rupees. So more than 1,800 crore rupees have been distributed to various news channels, such as the BBC, the NBC, Al Jazeera, the Guardian, the Financial Times. Now, these are big names. These are names associated with great integrity and objectivity. But the fact still remains that the big philanthropist who is deeply connected with the global vaccination program has been dishing out donations to these news outlets. So one must be very careful about news percolating about the COVID-19 disease, especially about these 4 cases and now the 5th case of reinfection. Now remember, there are only 5 reports of reinfection out of more than 25 million cases of COVID-19. Out of more than 2.5 crore confirmed cases of COVID-19, we have only 5 case reports of reinfection by COVID-19, by the reinfection by the China virus. And even these 5 reports are yet to be published in a peer-reviewed journal. The last report is of a British woman who is only 31 years. Apparently, she got infected some months back, and then she had, at that point of time, she had mild symptoms of fever, headache, myalgia. And when she became COVID negative by the PCR test on 2 occasions, she came back. And before she came back to work, she got herself tested again. And this time she has again become COVID-19 positive. So this is a case of reinfection. But what is not dilated upon is what were the antibodies in this woman. Whether she was tested for antibodies the first time, whether she was tested for antibodies the second time. And this is just a news report in a newspaper called the Evening Standard, by which any standard is a small newspaper with limited distribution in England. This is yet to be examined. The Health Minister of England has said publicly that he would get this particular case examined by British scientists. So we must wait for that report, bearing in mind that there can be always false negative PCR tests and there can always be false positive PCR tests. And we must know whether this young woman was antibody positive or negative the second time, because if she was antibody positive, and because of the fact that she was asymptomatic on the second occasion, that means when she apparently has been infected the second time, this means that her antibody response was adequate and it is working, like what was happening with the Hong Kong man who was 33 years, who when he was found to be reinfected was completely asymptomatic but was having a good antibody response, which means that the antibodies ensured that even though he got reinfected, he did not develop symptoms. So that is something which you must bear in mind, that only a handful of people have been reported to be reinfected in the world. Now, apart from that, there is excellent information excuse me, regarding treatment of COVID-19. Now remember, the recovery trial, which randomized more than 6,000 patients, 6,000 moderate to severe critical patients of COVID-19 to dexamethasone, which is a corticosteroid, and showed for the first time that dexamethasone is a drug which actually significantly reduces mortality in patients of COVID-19. Now we have 3 more randomized trials, but of course much smaller, published in the latest issue of JAMA, which is the Journal of the American Medical Association. These 3 articles are accompanied by a meta-analysis and by an editorial. So it would be worthwhile that you examine these 5 articles in the latest issue of JAMA. The first randomized trial is an American trial which has 400 participants, and these were given hydrocortisone, which is a corticosteroid. One group was given hydrocortisone in a fixed dose of 50 or 100 milligrams 6 hourly. The second group was given hydrocortisone adjusted to the blood pressure, and the third group was given usual supportive therapy, and they found that at 21 days the clinical outcomes were better with the hydrocortisone as opposed to usual therapy. The second randomized trial again is a randomized trial and is from Brazil. This has 300 critical patients of COVID-19, and what they showed was that by giving 10 milligrams of dexamethasone for 5 days and 20 milligrams of dexamethasone for another 5 days, this group as compared to usual therapy reduced the ventilator-free days from 7 days to from 4 days. It actually increased the ventilator-free days. It increased the ventilator-free days from 4 to 7 days when dexamethasone was used, which means that dexamethasone was treating these people in the right manner. It was effective. Also, in this study of almost 300 critically ill patients of COVID-19, quite a few of them who were on ventilators, 2/3 of them were on blood pressure improving drugs, what we call inotropes or vasopressor therapy, and also almost 1/3 of the usual treated group had received at least one injection of a corticosteroid. So this Brazilian study again, which is randomized, suggests very strongly that in a short period of 21 days or 28 days, the use of dexamethasone improved clinical outcomes significantly in patients of serious COVID-19 disease. The third study is a French study. It is a small one, which is underpowered, has only 150 patients. But again, this shows that clinical outcomes at 21 days were present more times in patients who were given hydrocortisone as compared to usual therapy. Then we have the meta-analysis. The meta-analysis has 7 randomized trials and includes 1,700 patients, 1,700 serious critical patients of COVID-19. This includes, of course, these 3 trials which I mentioned, and also the recovery trial, the big British trial. And the results are fascinating. Dexamethasone reduced mortality within a month by almost 35%. Hydrocortisone reduced mortality by 30%, and methylprednisolone reduced mortality by 9%. So the signal, the message is very clear that if we have a patient of COVID-19 who is in a serious condition, is demanding oxygen, or also has deteriorated to the extent that the patient needs a mechanical ventilator, the good drug of choice to reduce mortality is a corticosteroid. It could be dexamethasone or hydrocortisone. Both are cheap drugs, both are inexpensive, and both are freely available in this country. So if someone says that, look, our rural places have no infrastructure, the answer to that is very simple. I'm sure in just about every small town of India, dexamethasone or hydrocortisone will be available, and these can be easily administered by an injection, by even a non-medical doctor, even by an Ayush doctor. And also, dexamethasone can be used orally in a dose of 6 milligrams per day, which was used in the British study called the recovery trial. Because we have these doomsayers who keep coming back and who keep getting these platforms, unfortunately, who keep getting these international platforms as well as the national platforms, and who keep reminding us that the medical infrastructure in India is all tattered and it's all in breaking point, that we would be unable to handle the crisis, that millions and millions and millions would be infected, that millions will die by COVID-19. Watch out, there is a second wave coming. Watch out, there would be a third wave coming in very soon. Now all these, as far as I'm concerned, are nonsensical, because we have the information. Most Delhi's and hospital are now not getting in patients of COVID-19, and even if they are getting patients of COVID-19, these patients are not of serious nature. Death rates are declining. I agree that more and more cases are being picked up, but that is because we have drastically ramped up our testing for COVID-19 in this country. Right now we are doing lakhs of tests in a day, so we are bound to pick up more cases. But keep in mind that the population is young, so even though a person is infected, a person in his teens or in his 20s, even if that person is infected, the chances of that person becoming very sick or dying is quite remote, as has been suggested by the British study. Let me repeat what the British study has said. It has said that not a single child died, not a single young person below the age of 19 years died who did not have serious disease, right? The healthy just do not die. These were people who were infected, who were confirmed infected cases by PCR testing. So that should be very reassuring. Now, I will come to the editorial. The editorial is also very good in JAMA on these 3 randomized trials and the big meta-analysis. And the editorial rightly points out that there are still a few questions that have to be answered regarding corticosteroids, but are now more or less satisfied that the way to go about in this disease is that when a patient becomes sick, that is the point when the patient has unleashed a antibody or a counter-inflammation program, and the body is in a hyper-inflamed state, and this hyper-inflamed state, the antibodies, the immune system of the person concerned is now in fact targeting the person's own organs. And the fancy name, the technical name for this is called the cytokine storm. And when this stage is reached, and this stage can be picked up when you're reaching the stage is by the clinical condition. And more important, you have these markers, you have the ferritin levels, you have the CPK, you have the CRP and the LDH. When they start to rise rapidly, and if the oxygen level stays put or is dipping, you know that the patient is now heading towards a cytokine storm. So this is the time when you must give corticosteroids. The corticosteroids are easily available. They are less than 10 rupees an injection, and they would be very, very effective. And apart from the steroids, we also have Remdesivir, which is a different type of drug, which I have again mentioned earlier, has not been found to reduce or to cut death rate significantly. It does improve the clinical outcomes in patients. It improves the symptom state of the patients, but it does not reduce mortality. This is an expensive drug, but this has to be given much earlier. This is an antiviral drug which acts against the enzyme polymerase, which is produced by the China virus. So Remdesivir has to be used much earlier, within a week of symptom onset. The earlier the better. And then, in case the Remdesivir does not work, then we always have Dexamethasone or hydrocortisone at our disposal, and which has shown to reduce mortality significantly. Then we also have convalescent plasma, which has been a victim of a lot of politics in the United States of America. I have mentioned that there is only one randomized trial, a small Chinese randomized trial, which showed that convalescent plasma, when given early, does improve clinical outcomes, though it does not decrease mortality significantly. And the Americans also have now massive data. And though not randomized, they have data on thousands and thousands of patients who have been given convalescent plasma. And the mantra or the message is that plasma should be given as early as possible within 3 days of symptom onset, and the plasma which is administered must have high titers of antibodies. So if you give high quality plasma with high quantity, high titers of antibody in it, quickly before 3 days or 4 days of symptom onset, you are bound to improve clinical outcomes and you are bound to reduce mortality. So right now we have 3 modalities to treat COVID-19. We have convalescent plasma, which must be given early. We have Remdesivir, which again must be given early because both the plasma and Remdesivir function as antivirals. The antibodies in the plasma attack the virus directly. And after this, after a week or 10 days, if the patient continues to deteriorate, the oxygen is not improving, the patient is demanding more oxygen, we would have corticosteroids at our disposal, which are being manufactured in India and which are easily and cheaply available in just about every big city and just about every big town in India. So, I keep telling you these facts. I keep telling you that COVID-19 is something which has to be taken seriously, but we must not allow ourselves to be terrorized. We must not allow ourselves to be paralyzed with fear, because maybe that is the agenda of some people. Maybe that is the agenda of some philanthropists, or maybe that is the agenda of big pharma. And via them, it is the agenda of media outlets across the world and also in India. So do not get scared. Always do the research yourself. Always Google these facts, or always go into websites which give you facts, which give you peer-reviewed journals, or which give you peer-reviewed transcripts or manuscripts which are available. These are available in medRxiv. And of course, all the journals, whether it is JAMA, the New England Journal of Medicine, whether it is the Lancet, whether it is the Annals of Internal Medicine, or whether it is the British Medical Journal, all these journals provide data on COVID-19 free of cost. You don't have to buy an article. Now, which brings me to another big study which has been done by the Icelanders. This is an excellent study which again was published in the last 3-4 days by the New England Journal of Medicine. This is a large study which also had an editorial. This is testing antibodies in 30,000 people in Iceland. 30,000 people were tested by 4 antibodies. The tests that were used were multiple, but the most important fact is that these tests were targeting the nucleic acid of the China virus and also the spike protein of the Chinese virus. So therefore, these were comprehensive tests. And crucially, the researchers tested 30,000 people. And of these, more than 1,000 people were tested on 2 occasions, one at 0 day and the second time after 4 months. And what did they find? They found that almost all people who had COVID-19 had a strong antibody response, and above all, the antibody response was maintained for 4 months. So if someone tells you that antibodies are waning after a month or 2 months, do not believe them. This study clearly demonstrates that people have a robust COVID-19 antibody response of the IgG variety. There is a quick initial response, and then there is a sustained response which is present for at least 4 months. Apart from this, this study also suggests that almost 30% of people were asymptomatic, and that is the situation across the world. Any place where you do antibody testing, you realize that 30 to 40% of people never developed symptoms of COVID-19, despite being infected by the China virus. So, in a nutshell, though people may get reinfected, they would invariably have a strong antibody platform. They would be having antibodies inside their system, which would make sure that the second infection remains asymptomatic or is of the mild variety. And please keep this in mind. Now, enough of COVID-19. Let me quickly recap on COVID-19, not in order of how I spoke, but the important thing is that there is a robust antibody response. The antibody response lasts for at least 4 months. Children are just not seriously infected, and 1% or less children have died of COVID-19 in Great Britain. And sadly, all these 6 children had serious diseases, which means that if you are a healthy child, your chances of dying of COVID-19 are almost non-existent. The mortality in India is very low, despite the fact that officially 4 million people have been reported to be infected. I will repeat the phrase reported to be infected, because we have no confirmation that these people are actually infected, and we have no confirmation of the fact that 70,000 people have died. Bearing in mind that in the good old days, in a single day in India, almost 25,000 people died of various causes. So even if 70,000 people have died so far, over a span of 6 months, that is a casualty rate of just 3 days. Now, when I say this, I am not being dismissive of mortality. My condolences are always there. My heartfelt condolences are there with the families which have been victims of COVID-19. But the fact remains that mortality in India is very low because of COVID-19. I do not anticipate a second wave, nor do I anticipate a third wave, but we must be not complacent. We must follow the simple rules. We must employ hand hygiene. We must wash our hands as many times as possible. We must wear a mask in crowded places, especially when we are traveling in a bus, or when we travel in the metro, or when we go to the mall, or when we go to the bazaar, which is crowded by people, and we must maintain some distance from strangers. If we follow these simple rules, then I do not see a second wave of COVID-19 in this country. Now we move on from COVID-19 to the European Society of Cardiology meeting, which has brought out this big information on the SGLT2 inhibitors. I have already spoken about this new class of anti-diabetic drug, which is called the sodium glucose cotransporter 2 type inhibitors, and there are 2 of them. Both of them are present in the Indian market. They are being manufactured by Indian companies also. First is empagliflozin. The second one is DAPA-CKD. Now we have the DAPA chronic kidney disease data also, which was presented in the ESC a few days back. This had more than 4,000 people with the chronic kidney disease. Almost, I think probably 65% were males. The average age was in the early 60s. The GFR ranged from 25 to 75 mil per minute, and almost 15% patients had a GFR less than 30%. 45% had a GFR between 30 and 45 mil, and 40% had a GFR between 45 and 60. Right? So therefore, these were people with compromised kidneys. They were followed for more than almost 2.5 years, and what was found was that deterioration in renal functions was reduced by almost 40%. Deterioration in renal function was defined as a doubling of creatinine value, the need for dialysis, or kidney mortality. This was reduced. Progress in this was reduced by 40% by dapagliflozin, and cardiovascular mortality accompanied by hospitalization for heart failure was reduced by almost 30%, and all-cause mortality was reduced by 30%. So the signal is there that dapagliflozin, a drug primarily used for diabetes, will prevent kidney outcomes, will prevent cardiac outcomes in people who have injured kidneys and injured hearts. And an important fact is that the DAPA chronic kidney disease study included almost 25 to 30% of people who did not have diabetes. So dapagliflozin will work in diabetics and also in non-diabetics. So the mantra is simple, that the use of dapagliflozin in a patient who has kidneys compromised or who has some heart disease, we would get good clinical outcomes in a significant proportion of patients. The other big study, which has been published in the Lancet, is a meta-analysis which includes both the Emperor Reduced trial, which used empagliflozin in patients of heart failure, and the DAPA heart failure trial, which was published last year. Now, this has now 8,400 people of heart failure, half of them who are not diabetics, half of them who are diabetics. The left ventricular ejection fraction is reduced, and the average ejection fraction was 28 to 29%. So therefore, these patients were of the HEF-REF variety, heart failure with reduced ejection fraction. And what this meta-analysis found was that a follow-up of almost 1.5 to 2 years showed that there was a reduction of hospitalization by heart failure and cardiovascular mortality by as much as 30%, and renal outcomes were reduced by almost 40%. So the signals are pretty solid, are quite clear. I do admit that these trials have been sponsored by drug companies, but there is robust evidence of efficacy of empagliflozin and dapagliflozin in patients of HEF-REF, that is patients of heart failure with reduced ejection fraction, and patients with compromised kidneys. And dapagliflozin can be used in patients who have GFR less than 30% or almost hovering around 30%. Now, I've already mentioned that the EMPEROR trial, which used empagliflozin, had more serious patients as compared to the DAPA heart failure trial. The ejection fraction in EMPEROR reduced was 27% as opposed to 31% in DAPA. The NT-proBNP levels were 1,900 in the reduced trial, EMPEROR reduced trial, as opposed to 1,400 in the DAPA heart failure trial. And the GFR was 61 ml as compared to 66 ml in the DAPA heart failure trial. I just forgot to mention that the DAPA chronic kidney trial had an average GFR of just 44 mils. So SGLT2 inhibitors can be used with almost impunity in patients suffering from previous myocardial infarction, with patients suffering from a previous stroke, with patients having coronary artery disease, with patients having unstable or stable angina, and in patients with moderately compromised kidney function. And the side effects in all these trials have shown that the side effects or adverse effects were the same as compared to placebo. The side effects have been considered to be fractures, they were the same, have been considered to be fungal infections, but the genitalia fungal infections have been found to be more with empagliflozin and dapagliflozin, but these can be easily managed. The other side effects are amputations, which were the same, and acidosis, which again were the same as compared to placebo. So the drugs are pretty safe to be administered in these patients. Now, the last topic which I will touch is on prasugrel. Now, we invasive cardiologists have been using ticagrelor when we do angioplasties in patients of unstable angina, non-STEMI or STEMI, based on the Plato trial and the Plato sub-study, which showed a clear, significant reduction in the clinical outcomes of death, myocardial infarction, and stroke when ticagrelor was compared to clopidogrel. So based on that, the professional guidelines suggested that ticagrelor should be the number one choice and should be placed above clopidogrel when we went for an invasive strategy. However, last year there was a big randomized trial done not by a drug company but done by investigators in Germany. This had almost 2,500 patients of acute coronary syndrome. 45% were patients of non-STEMI, 40% were patients of STEMI, that is the regular heart attacks, and 15% patients were of unstable angina. And more than 90% of these patients were subjected to angioplasty with stenting. And these were divided into two groups. One group was given prasugrel, the other group was given ticagrelor. Both are P2Y12 inhibitors. And to the surprise of the researchers themselves, prasugrel turned out to be superior to ticagrelor. The clinical outcomes of death, myocardial infarction, and stroke were significantly reduced by an absolute 2% from 9% to 7% when prasugrel was used as compared to ticagrelor. And so therefore, now the ESC, the European Society of Cardiology guidelines, the latest ones on acute coronary syndrome, suggest that this is a 2A indication, that prasugrel could be preferred to ticagrelor if an angioplasty stenting technique is adopted in patients of non-STEMI or STEMI or patients of unstable angina based on the ISAR-REACT 5 trial, which, as I have just mentioned, was not a drug company sponsored trial but was an investigator sponsored trial. The study is published in Lancet, and I will give you a link to this trial. And based upon this trial, the latest ESC guidelines emphasize that prasugrel can be preferred to ticagrelor when you subject a person of non-STEMI or STEMI to PTCA with stenting. So with that, I think this has been a long talk. If you have enjoyed this talk, or if you think that you have gathered some new information or gathered some knowledge, do press the bell icon and do subscribe to this channel, and also please do share it with your friends and colleagues. Well, I try to make things as simple as possible, but you must appreciate that I'm talking pure science, and sometimes science can be a bit difficult, and simply reading out abstracts of trials is not good enough. I try to extract or distill the data from these trials, and I try to be as objective as possible, because I'm not sponsored by any drug company or by any media outlet. Now, having said that, this is goodbye. Have a good Sunday, or rather, today's a Saturday. Have a good Saturday, and have a good weekend, in fact. Thank you very much for listening to me. Thank you very much once again.